This is a presentation on the comparison of adductor canal blocks and femoral nerve blocks for patients undergoing total knee arthroplasties by Jordan Gallus and SRNA at the University of South Florida. 6.7% of Americans have undergone a total knee arthroplasty, or TKA, which means that this is a surgery we're going to see fairly frequently. TKA is associated with significant postoperative pain, and this pain must be managed to enhance patient ambulation, physical therapy participation, maintaining joint range of motion, and all of these things are necessary to facilitate hospital discharge. Single pain management modality using opioids alone has many drawbacks, which include increased falls, respiratory depression, nausea and vomiting, and all of these things prolong hospital stay. A multimodal pain approach, including regional anesthesia, can be used to limit opioid consumption and all of those negative side effects. The femoral nerve block is both a sensory and motor block, and historically has been the block of choice. While they do decrease postoperative opioid requirements, they have been associated with quadricep muscle weakness. This weakness delays the patient's onset of participation in early ambulation, as well as physical therapy, and also increases fall risk. This delay in rehabilitation process ultimately could contribute to increased costs in hospital stay. The adductor canal block is a purely sensory block that is now being utilized by many hospitals due to its minimal effects on quadricep muscle strength. As an anesthesia provider, one should always aim to provide cost-effective, safety-focused care utilizing the most current evidence-based practice research to give their patients the best post-operative outcomes. Our PICO question is, in patients undergoing a total knee arthroplasty, how does the use of the adductor canal block compared to femoral nerve block affect postoperative day 1 quadricep strength and ambulation? Breaking this down, so the P, which is patient or population, would be patients undergoing a total knee arthroplasty, TKA. The I, which is the intervention, is the use of the adductor canal block. The C, or comparison, is the femoral nerve block. O, which is outcomes, would be our quadricep strength and ambulation, and then T, which is time, is postoperative day 1. So, for the literature search strategy, the University of South Florida created an online tool that combines all databases into one search. This all-in-one search was used for collecting relevant studies that address the PICO question. Databases used were Medline and PubMed, CINAHL, and ScienceDirect. Key terms used were adductor canal block, femoral nerve block, total knee arthroplasty, quadricep strength, and ambulation. A basic search with these terms resulted in 650 studies, which is a lot. With the advanced search, limitations were made to include studies that were only in English, studies that were full-text articles, and studies that were published between 2013 and 2018. The Boolean operator AND was also used, and that helped us to get more on-target results by removing articles that did not include total knee arthroplasty patients. The results were then narrowed down to 64 studies with this advanced search. Of the 64 studies, after reading the title and also the abstract, several studies were eliminated, either because they did not address all aspects of the PICO question, they were duplicates. Also, several articles did not use the femoral nerve block as the comparison group, or they did not have quadricep strength or ambulation as an outcome that was measured. Following all of these eliminations, there were 9 studies that reached the criteria, of which 7 were chosen to be appraised for with this project. The first study was a level 1, good quality, randomized control trial by Grevstad et al. That was conducted in a hospital in Denmark. There was a total of 49 participants in the sample size, who were randomized and blindly placed with 24 into the femoral nerve block group and 25 into the adductor canal block group. The primary outcome of the study was to compare the effect of the 2 blocks on maximum volume isometric contraction, which is MVIC, of the quadriceps muscle relative to a post-op baseline value. Secondary outcomes evaluated were the ability to ambulate and also changes in pain scores. The results that they found concluded that quadriceps MVIC increased 193% in the adductor canal block group, and it decreased 16% in the femoral nerve block group. They also found no significant difference in pain scores between the two groups. Limitations of the study were that they evaluated only the immediate effects, so we do not have any information on the duration of the effects or long-term benefits of using the adductor canal block. The second study is a level 1, high-quality, prospective, double-blind, randomized control study by Heges and Sultan, conducted in a hospital setting in Egypt. The sample consisted of 107 patients, 54 allocated into the femoral nerve block group and 53 patients allocated into the adductor canal block group. The primary outcome tested was the effect on quadriceps muscle and also early ambulation, determined by the timed up and go, or tug, test, and also the 10-minute walk test. The secondary outcome measured was numeric pain scale ratings, opioid consumption, and hospital length of stay. They found that the adductor canal block group was able to perform the tug and 10-minute walk test on post-op day 1, where 2 patients that were in the femoral nerve block group were not able to complete the walk test on post-op day 1 because they were a fall risk. Overall, the adductor canal block group performed both tests significantly faster than the femoral nerve block group on post-op day 1. There was no significant difference in pain between the femoral nerve block group and adductor canal block group. Limitations of this study were that they do not describe who it was that was conducting and recording the tug test and this 10-minute walk test. So we don't know if it was one single person, multiple professionals, if they were nurses, physical therapists, a research team member. So we're unable to know if there was consistency and accuracy in the data recorded. The third study is a level 1, good quality, prospective randomized controlled trial by Kim et al., conducted in a hospital for special surgery. The sample consisted of 94 patients, 46 in the adductor canal block group and 47 in the femoral nerve block group. In this study, patients received either block as a component of a multimodal analgesia plan. They monitored quadriceps strength via dynamometer testing, as well as pain scores and opioid consumption at 6, 8, 24, and 48 hours post-anesthesia. They found that at 6 to 8 hours post-anesthesia, the adductor canal block group exhibited early relative sparing of quadriceps strength compared to the femoral nerve block group. They found no difference in pain scores or opioid consumption between the two groups. Limitations of the study were that the duration of the analgesia from the adductor canal block group is unclear and was also not measured. They suggested in the future performing the adductor canal block group on one leg and the femoral nerve block group on the other on the same patient who's undergoing a bilateral knee arthroplasty to compare effects with having less intervening factors. The fourth study was a level 2 high-quality meta-analysis conducted by Kwong et al. Through PubMed, Embase, Web of Science, and Cochrane Library database searches, 7 studies were selected for the meta-analysis, 4 randomized controlled trials and 3 case-controlled trials, which totaled 828 patients. Results from the meta-analysis were that there were 2 studies totaling 150 knees that showed the adductor canal block performed significantly better in the tug test. 4 studies showed the adductor canal block ambulation distance was significantly farther. 4 studies showed that the VAS at rest and ambulation scores, as well as opioid consumption, all had no significant difference between the 2 block groups. Hospital length of stay assessed in 4 studies showed no significant difference. Limitations are that if they would have included more studies, they could have had more data on ambulation and muscle strength, yielding more power and validity in their results. The fifth study was a Level 1 good quality systematic review and meta-analysis conducted by Lee et al. The databases PubMed, Web of Science, Embase, and Cochrane Library were systematically searched. Of 66 records identified, 8 randomized controlled trials were eligible for data extraction and meta-analysis according to criteria included. Sample size of 8 randomized controlled trials of 434 patients total, 249 in the adductor canal block group, and 255 patients in the femoral nerve block group. The results of meta-analysis showed that quadriceps strength, tug test results, 10-meter walk test, 30-second chair test, and ambulation were all significantly better in the adductor canal block group versus the femoral nerve block group. They also did not find any significant differences in the pain scores between the two groups. Limitations of this meta-analysis were that it was a relatively small sample size, funnel plots were not available, anesthesia and analgesia methods in the trials were different, and there was heterogeneity present. The sixth study was a Level 1, high-quality, prospective, double-blind, randomized control study conducted by Macrinci et al. At Presence St. Joseph's Medical Center in Illinois. They compared the adductor canal block and the femoral nerve block using baseline maximum voluntary isovolumetric contraction, MVIC, of the quadriceps muscle at 6 hours, their primary endpoint, but also at 24 hours, 48 hours, and 6 months post-op. Their secondary endpoint included the timed up and go test, range of motion, a 6-minute walking test, pain scores, and post-op pain medication use. The sample size was 93 patients. 46 patients were in the adductor canal block group, and 47 patients were in the femoral nerve block group. They found that the adductor canal block group retained a higher percentage of baseline MVIC and also performed better on the tug test than the femoral nerve block group. They did not find any differences in VAS pain scores. Limitations to this study were the lack of a placebo group, which they had justified due to ethical considerations. The seventh study was a Level 1, good quality, randomized controlled trial by Shah and Jain, conducted at Workpart Hospital in Mumbai. The sample size was 100 patients. 50 received a continuous adductor canal block and 50 received a continuous femoral nerve block. Adductor canal block and femoral nerve block were compared by assessing patients for pain at 4, 8, 12, and 24 hours postoperatively, also assessing opioid consumption and their side effects, if any. Ambulation abilities were assessed in the form of timed up and go test, the 10-meter walk test, and a 30-second chair stand test. The findings of the study showed that the continuous adductor canal block group showed significantly better results with the tug test, 10-minute walk test, and 30-second chair test. All continuous adductor canal block group members were able to perform the ambulation test, where 6 from the continuous femoral nerve block group could not. Limitations to the study were that there was inconsistency in the assessment timings for ambulation ability, since they evaluated everyone at a fixed time and did not account for the differing timing of surgeries. So now that we've gone over the results of every study individually, it's time to synthesize all of this material and data. The literature revealed that 2 studies showed maximum volume isometric contraction, that was the MVIC. They showed that was higher in the adductor canal block group over the femoral nerve block group. 5 out of the 7 studies showed the adductor canal block group scored better on the timed up and go, the tug test. 2 studies revealed the adductor canal block group scored higher on the 10-minute walk test. All 7 studies evaluated the VAS pain scores and opioid use and found that there was no significant difference between the adductor canal block group and the femoral nerve block group. So the adductor canal block group showed better preservation of quadricep muscle strength and improved ambulation in those first 24 hours postoperatively without compromising pain control. Gaps that were found through this literature review. There really isn't a lot of research showing the long-term effects of using the adductor canal block group over the femoral nerve block group. In addition, I feel that more studies should be done to show the impact on hospital length of stay and the impact on healthcare costs. So, based on all of the results, it's recommended that all surgeons and anesthesia providers preferentially choose the adductor canal block over the femoral nerve block when selecting a regional anesthesia technique as part of the multimodal pain relief techniques for total knee arthroplasty patients. By choosing the adductor canal block instead of the femoral nerve block, surgeons will find that their patients have improved quadriceps strength, leading to earlier ambulation, and they will find that there is no difference at all in pain. So why not choose the block that's going to lead to more strength and better ambulation? So now we'll develop our action plan. First, we need to identify our stakeholders. This is our sample. It would include surgeons, anesthesia providers, physical therapists, nurses, the chief medical officer, and chief nursing officer. The setting would be for a hospital, and our design is a quality improvement plan. For our procedures, first you want to appoint a project leader and also supportive change champions from the hospital. They will conduct an organizational assessment to evaluate the readiness of the organization for change. They will also assess the organizational culture and identify barriers and facilitators to the practice change. Since the adductor canal block could be a new skill, it is helpful to appoint an opinion leader. An opinion leader is usually a well-known individual in the practice group who is held in high esteem and is someone people usually come to for advice. They can influence the group's opinions for or against change and be a valuable resource for teaching the new skill. We want to identify observable measures. Ours would be the tug test and MVIC, and then develop a timeline for the action plan. We would identify critical milestones and the related tasks. So for example, we'd have a presentation to the surgeon, OR staff, PACU nurses, anesthesia providers, physical therapy, and ortho nurses on the evidence-based practice results with a quiz by week 3. And then we would have all anesthesia providers get checked off on the adductor canal block skill during weeks 4 through 8 and have a goal for completion of the practice change of week 12 of wanting to see surgeons requesting always to have adductor canal blocks, anesthesia providers utilizing adductor canal blocks, and having post-op data collection. So the data collection and analysis occurs by compiling the data of the tug test and MVIC scores. Dissemination of findings occurs, and one creates a poster to present to stakeholders and also to other organizations. This concludes the evidence-based practice presentation.